Thank you, Zena, and the rest of the team for a fantastic presentation. So my name is Henry Okonkwo. I'm from the United States, and I participated in a few of the different clinical trials that I'll be talking about today. My job is to actually sort of bring it all together and talk about how we've had challenges with looking at the current standards of a clinical assessment today when we talk about preventing pressure ulcers. Our gold standards are typically looking at the Braden, the Waterloo, or the Norton, or relying specifically on clinical judgment and physical exam. And as we all know, we've talked about it before throughout the day, as well as especially, I know we've leaned a lot on Dr. Coleman's presentation, and I really want to lean some more on it because I think they're doing a fantastic thing by trying to improve the risk assessment tools that we have out there, because that's currently our gold standard when we're trying to measure or prevent pressure ulcers and indicate them when they occur. And then as far as physical exam, we know that we're extremely limited because the ability of a nurse to perform a really good clinical exam and to identify a pressure ulcer is really limited by her experience or his experience. And so having an objective tool eventually in the future to be able to assess that, it really becomes a game changer, because then we actually begin to objectify the information and not subjectify it. So ultimately, the challenge in our clinical design was to create an environment where we could determine the validity of the actual study in the absence of the standards of clinical studies right now, which is looking at physical exam and also looking at the patient's risk assessment tools. So for us, definition of validity is the ability of the test to indicate which individual has a pressure ulcer or which one did actually not have a pressure ulcer. The classic conundrum is looking at the gold standards. But ultimately, the real challenge is no one really wants to participate in a true double-blind study where they're at risk for developing pressure ulcers without us actually intervening. And intervention is the big deal, because ultimately we want to make sure that we're intervening along the way as patients are at risk for developing pressure ulcers. So this creates the third challenge, which is really a limitation in clinical design. What can we really do to actually honestly be able to validate the specificity and sensitivity of the machine? So a random double-blind study obviously is not a great option. Why? Because ethically we don't want pressure ulcers to occur and us not do anything about it. And then of course it's very difficult to recruit patients knowing that this is actually going to happen. So it really leads us to our classical condition now, which is being able to really design a longitudinal study. In the early studies, we originally looked at patients who did have pressure ulcers to try to validate the machine. And so when looking at patients who identify with pressure ulcers, we scanned them, and the machine 91% of the time was able to identify that they really did have a pressure ulcer, because you had an elevated SEM reading greater than a delta of 0.6. And then for patients who did not have pressure ulcers, the machine was able to identify 86% of the time that they did not have a pressure ulcer, and they were not identified with a pressure ulcer. So this led to our eventual longitudinal study. So what can we do over time to actually start to assess how well the SEM scanner can identify pressure ulcers potentially before they're visible to the naked eye? Here's a picture of the scanner. And so the objective of the presentation is to evaluate the use of the SEM scanner as an adjunct to the clinical judgment for early detection of pressure ulcers and in patients before clinical judgment is virtually identified. So literally looking at the risk assessment tools and combining that, as Zena said, marrying it to a tool that can actually identify the pressure ulcer potentially before you visually see it. The method of the examination or of the study was multi-prospective. We were able to recruit 189 patients throughout multiple sites throughout the United States and the UK, and most of them being in a hospital setting, the skilled nursing facility, or an elder home or long-term care facility. We recorded SEM values as well as did a visual skin exam. So we broke up our team into two teams. First team are generalists, and those actually use the SEM Scanner, which I actually was a generalist for the study, and use the SEM Scanner to scan the skin on high-risk areas daily up to 20 days. And another person who is a specialist would actually examine the skin daily using the traditional risk assessment tool and clinical judgment and physical exam to hopefully identify a pressure ulcer as soon as it occurs. Participants were blinded to each other, so we didn't know what each other were doing. And ultimately, a positive SEM reading would be that you had a SEM scanner reading of 0.6 or above. And then, of course, a positive visual skin exam would be a non-blanchable redness or, a more acute wound. There was 189 subjects, 47% of them female, 53% of them male, and racial breakdown was 67% white, 24% Asian, 4% black, and 5% others. We looked at the BMI for all the participants with the mean BMI of 26.01 and or 26.78, a medium of 26.01, and age variant between 79 years old for females for mean and 73 years old for males. Ultimately, we created inclusion and exclusion factors. Inclusion factors were you had to be an age of 55 years or older, risk of developing a pressure ulcer, meaning that your risk assessment tool did identify that you were at risk for developing a pressure ulcer, so you had a very low Braden or Norton score. Poor mobility, obviously, poor nutritional status, or a predisposing medical condition that limited your ability to move. Exclusion factors included having an unhealed pressure ulcer. So if you had an unhealed pressure ulcer, you were not going to be allowed to participate in the study, as well as having broken skin. The SEM scanner, we want to make sure it was reading skin that was intact and not skin that was already broken or damaged. And also, we wanted to make sure that there was moisture lesions. Anyone who had an MASD, moisture-associated skin damage, type of skin breakdown were not allowed to participate in the study. So the final data from the study was that we were able to identify 55 pressure ulcers occurred during the course of the study. And so the key with the 55 pressure ulcers that occurred was what type of pressure ulcers were they, and then ultimately how early was the SEM scanner able to identify these pressure ulcers prior to the visual assessment or the visual identification of these pressure ulcers. So in totality, stage 1 pressure ulcers that occurred were 37 pressure ulcers. Stage 2 were 5 pressure ulcers. And stage 3 and 4 were none. And then unstageables, there were 2 unstageable pressure ulcers that were identified. And then approximately, there was actually 11 deep tissue injuries that occurred during the study. Now, the most important slide, and this is actually my favorite slide, was because this slide really identified the value of the SEM scanner. The SEM scanner was able to, out of that 55 patients, were able to identify pressure ulcers up to 12 days prior to the actual visual identification of the pressure injury. And that's a big deal because in wound care, especially on the clinical side, we're always talking about prevention, prevention, prevention. And you can put a lot of prevention tools in front to try to decrease a person's pressure ulcer from developing. But to actually have a tool that actually was able to identify it 12 days prior to was really made a huge difference in our clinical planning and management. So overall data, there were 2 patients that are identified 1 day prior to, 5 patients identified 2 days prior to, 8 patients up to 3 days prior to, but really the main one was 5 days prior to, where we had the most amount of identified patients, where we had 13 patients identified prior to the visualization of the pressure injury. And what I found really exciting was that even for the stage 2 pressure ulcer, we were able to identify it 12 days prior to the actual visualization of the injury. So one of the things I wanted to do was compare what happens to patients when they received intervention versus when they didn't. And this is actually a sample taken from one of our patient population. We looked at the Braden score between 2 patients. We're calling healthy are the patient who did not develop a pressure injury, and then unhealthy is the patient who did. The Braden score for the 2 were considerably low, obviously a little bit lower for the patient who did develop a pressure ulcer, but intervention-wise, they both received turning measures as directed, which is for the most patients is Q2 hours or more often. They both originally started with using a lower air loss mattress. But within a few days, for whatever reason, one of the facilities decided to remove the lower air loss mattress, usually because of cost, and place a static pressure relieving mattress for the patient. And as you can notice from the graph, the moment the pressure relieving mattress was removed, the patient's SEM score started going up rapidly. And even though quickly they reinstated the SEM, they reinstated the offloading mattress, the lower air loss mattress, it was too late. The patient's SEM scanner readings continued to elevate till eventually they developed a visual pressure injury. And that's really significant because if you notice the patient who did not, they received ongoing continuous preventive measures, and they did not develop a pressure ulcer. So number one, having a device that actually can identify it as soon as it happens is critical to preventing an injury. And then of course, keeping your risk assessment, your risk prevention tools in place the entire time is critical to the prevention of a pressure ulcer. So in conclusion, the SEM scanner is a new technology that can accurately detect the development of pressure ulcers, even when there is no visible sign of damage. And Zena really hit the point on that by noting that it's extremely critical to have a tool that can look under the skin and not just depend on us looking visually at what's on the surface of the skin. The SEM scanner can detect damage on average 5 days, but up to 12 days prior to the visualization of a pressure injury. With early detection and with the window of prevention, intervention can be reversed. So early detection will always lead to early prevention. Current standards of care are not sufficient for prevention. As we know, we're depending currently on just visual assessment and depending on the risk assessment tools, it's not as easy to prevent pressure ulcers. But if we can identify them prior to their development, it becomes really critical and a game changer. In clinical practice, objective scientific data from the scanner gives clinical confidence to take action. So when you know exactly what's happening with your patient, you know that you can make drastic changes right away in the effort of preventing these pressure injuries. Early detection using the SEM scanner is now being adopted in clinical practice across the United Kingdom as well as Canada. And so hospitals that are using the SEM scanner have seen really dramatic reductions in their hospital-acquired pressure injuries to the point where it's been zero for some of the facilities as well, which of course drives down cost and gives a better intervention opportunity for any facility that participates in its use. SEM scanning will become the gold standard in ulcer detection and diagnosis. We really believe that over time, using the SEM scanner as an adjunct to managing patients and trying to prevent pressure ulcers is going to become a huge deal. So I'd like to close with this slide. It talks about prevalence of pressure ulcers throughout the United States, throughout the world. But in the United States, there's over 2.5 million pressure ulcers annually, and that's a big deal. And then in the UK, 20% of patients in acute care settings do develop pressure ulcers. And within that, 15% of patients across the world globally have pressure ulcers, and leading to almost 25%, 1 in 4 beds of patients that are being hospitalized having a pressure injury of some level. So actually having a device that can change the way we assess patients, preventing the development of this, because ultimately that's what we're trying to do, is that we don't want this to happen to our residents and to our patients. We want to make sure that our patients are being taken care of in a manner where we can hopefully prevent pressure ulcers from developing, and we can make a huge difference out there. So we really believe the SEM scanner is going to become a gold standard in the assessment and prevention of pressure ulcers. And we also ask that everyone continue to look to technology, because technology is making a huge difference in healthcare, and we should embrace it, because really the future of healthcare is going to be technology dependent, and the SEM scanner is definitely a leader in that field. Thank you very much.